Oral surgery is a critical aspect of dental and maxillofacial care, but like any surgical procedure, it carries risks of complications. Understanding these complications, their causes, and management strategies is essential for both practitioners and patients. In this video, we'll explore intraoperative and postoperative complications in oral surgery, focusing on soft tissue injuries, hard tissue issues, adjacent tooth damage, bone fractures, TMJ injuries, and nerve complications. By breaking down each category, we aim to provide a comprehensive guide for prevention and effective management, ensuring safer outcomes and improved patient care. Mucosal tears are among the most common intraoperative complications during oral surgery. These tears often result from improper surgical technique, such as inadequate flap size or careless handling of instruments. Excessive force, especially with elevators, can also cause mucosal damage. The upper posterior palate, lower tongue, and floor of the mouth are frequent sites for these injuries. Prevention involves proper flap design, controlled force, and careful handling of instruments. Small tears usually heal by secondary intention without closure, while larger tears require direct closure for primary healing. Understanding these nuances helps minimize patient discomfort and promotes faster recovery. Punctures and inadvertent incisions can occur during oral surgery due to uncontrolled force or lack of attention while handling surgical blades. Elevator slipping is a frequent cause of punctures, especially on the lips and cheeks. Prevention strategies include using controlled force, proper finger rest, and employing the index finger as a stop on elevator shanks. Deep punctures should be left open for drainage to prevent entrapment. Healing by secondary intention. Small incisions typically do not require suturing, while larger ones should be sutured and Vaseline applied to minimize scarring. These steps are crucial for reducing postoperative complications and improving healing. Thermal injuries in oral surgery are often caused by using hot instruments straight from the autoclave or by handpiece overheating. Crush injuries occur when lips or cheeks get entangled in forceps during molar extractions, while abrasion injuries result from long burr shanks rubbing against soft tissues. Prevention includes cooling instruments in saline, regular maintenance of rotary tools, and adequate soft tissue retraction. Management involves palliative care, cold or hot packs, topical Vaseline, and proteolytic enzymes like serratiopeptidase. These measures help reduce pain and promote healing, ensuring patient comfort during recovery. Ecchymosis, or secondary internal bleeding, is a complication that absorbs spontaneously within 1 to 2 weeks. Treatment involves cold or hot packs and reassurance to the patient. Surgical emphysema occurs when air is pushed into tissue spaces, often from air-driven turbine drills. This condition develops rapidly and is characterized by a crackling feel under the skin. To prevent surgical emphysema, avoid using air-driven turbines for bone or tooth sectioning. Recognizing and managing these complications promptly is vital for patient safety and comfort. Fractures of teeth and roots are hard tissue complications that often arise from inappropriate or excessive force, lack of prior elevation, or abnormal root morphology. Carious lesions, large restorations, and devitalized or ankylosed teeth are particularly susceptible. Ideally, all root fragments should be removed unless their removal poses a hazard, such as proximity to the inferior alveolar nerve or antral floor. Management decisions depend on tooth vitality, root length, infection status, and patient cooperation. It's important to inform patients and document any retained fragments for future reference. Teeth or root fragments can be displaced into spaces such as the submandibular space, pterygopalatine fossa, or infratemporal fossa, especially when the lingual cortex is thin. Immediate retrieval or referral to an oral and maxillofacial surgeon is necessary. Displacement into the maxillary sinus is common with palatal roots of maxillary first molars or teeth with splayed roots near thin antral floors. Confirmation involves the nose-blowing test, but it must be gentle to avoid creating a breach. Avoid probing blindly into the sinus to prevent further complications. Swallowing or aspiration of teeth and root fragments during oral surgery is a critical airway emergency. Aspiration into the tracheobronchial tree requires immediate referral to a chest surgeon for bronchoscopy. If the fragment is swallowed into the gastrointestinal tract, a gastroenterology consultation is necessary. Prompt identification and management of these emergencies are vital to prevent serious complications and ensure patient safety. Adjacent teeth and restorations can be injured during oral surgery due to misdirected elevators or improper forceps application. Subluxation, luxation, or fracture of adjacent teeth requires stabilization with wire or acrylic splints, keeping the affected teeth out of occlusion. Endodontic therapy may be needed if the pulp is compromised. Extraction of the wrong tooth is a serious error, often caused by carelessness or poor communication, especially in orthodontic referrals. Management includes checking charts, marking teeth with indelible pencils, informing the orthodontist and patient, and immediate replacement or reimplantation if possible. Major bone fractures, such as those of the maxillary alveolus, tuberosity, or mandible, are rare but serious complications. Maxillary tuberosity fractures are associated with over-erupted molars, large antra, or excessive force. If the bone is attached to the periosteum, it should be repositioned and sutured. If detached, removal is necessary. For large segments, abandon extraction and defer surgery for 6 to 8 weeks. Mandible fractures require radiographs, patient notification, and treatment via reduction and fixation. Instrument breakage, such as broken burr tips or elevator fragments, should be retrieved if possible or referred to OMFS with debridement. TMJ injuries, including dislocation and pain, can occur during oral surgery, especially under general anesthesia or difficult extractions without jaw support. Pain is usually due to stretching of the capsule and is managed with rest, soft diet, hot fomentation, and analgesics. Dislocation is treated by pushing the mandible downwards and backwards, rotating the chin upwards. Patients should avoid wide opening for a few days. Late supine hypotensive syndrome occurs in late pregnancy due to fetal pressure on the inferior vena cava. Management involves turning the patient to one side or elevating them to restore venous return and cardiac output. Hemorrhage during oral surgery can involve both bone and soft tissue. Bone bleeding is controlled with pressure gauze packing, bone crushing or burnishing with hemostats, absorbable gelatin sponges, or bone wax. Bone wax should be used sparingly due to infection risk. Post-extraction instructions include biting on a gauze pack for 10 minutes to form a stable clot and avoiding vigorous rinsing, touching, or chewing. These steps are essential for preventing excessive bleeding and ensuring proper healing. Alveolar osteitis, commonly known as dry socket, is a postoperative complication characterized by severe throbbing pain, foul odor, and disintegration of the blood clot, exposing bare bone. It is linked to bacterial factors, trauma, smoking, vasoconstrictors and local anesthesia, and oral contraceptives. Management focuses on pain relief and promoting healing, often requiring palliative care and patient reassurance. Recognizing dry socket early and providing appropriate care is crucial for patient comfort and recovery. Nerve injuries, particularly to the inferior alveolar and lingual nerves, are risks during third molar extractions, flap elevation, or bone cutting. These injuries can lead to sensory disturbances and require careful monitoring. Recovery may take 2 to 6 months, but severe cases might need microsurgical anastomosis, grafting, or nerve decompression by an oral and maxillofacial surgeon. Early identification and appropriate management are key to minimizing long-term complications and ensuring optimal patient outcomes. Complications in oral surgery range from soft tissue injuries to major bone fractures and nerve damage. Prevention is always better than cure, and it starts with proper surgical technique, careful instrument handling, and thorough patient assessment. Effective communication, accurate charting, and adherence to safety protocols are essential. When complications do occur, prompt management and patient reassurance are vital for recovery. By understanding these risks and strategies, practitioners can enhance patient safety and outcomes in oral surgery.